Hello, and welcome to your pre-lecture on renal function. I'm your faculty, Professor Brooks. The renal system is another integral and vital body system. We have referred to renal function in the past, and now we will explore the structures and processes that occur in this system in more detail. Notice when looking at the anatomical location of the kidneys that they are relatively high and not found in the pelvic area, but rather the lower abdominal cavity. They are situated on either side of the vertebral column between the 12th thoracic and 3rd lumbar vertebra. The right kidney is slightly lower than the left, being displaced by the liver, which overlays the kidney. This is important to know as nurses due to the assessment of costovertebral angle tenderness, which is indicated for renal inflammatory disorders, including but not limited to kidney infection. Functionally, the kidneys perform homeostatic, excretory, and endocrine processes. Excretion of wastes, maintaining water balance, conservation of nutrients, and acid-base balance are homeostatic functions of the kidneys. The excretion of fluid, wastes, and electrolytes in the form of urine is the second function, which overlaps the homeostatic function. Lastly, the kidneys function as endocrine organs, synthesizing and secreting hormones into the bloodstream. Renin, as we've discussed in many lectures, is synthesized and secreted by the kidneys in response to decreased renal perfusion of the juxtaglomerular apparatus. Erythropoietin, which is responsible for formation and maturation of erythrocytes, is formed by the kidney and in small amounts by the liver. Dihydroxyvitamin D3 is essential for calcium metabolism in the body. Lastly, the kidneys can perform glycogenolysis, the release of glucose into the bloodstream when needed and necessary. This image is a cross-sectional view of the kidney. The hilum is the indentation in the kidney where the renal vessels and the ureter enter and exit the kidney. The cortex of the kidney is the outer layer and contains most of the nephrons. The remaining nephrons are located in the medulla or renal pyramids. In these areas, urine is formed and flows from the pyramids into the renal calyces, from the collecting ducts, and into the renal pelvis. The renal pelvis is the upper extension of the ureter. The kidney is divided into lobes, with each lobe composed of a pyramid and the overlying cortex. Each kidney has about 14 to 18 lobes in total. At any given time, the kidneys hold 20 to 25% of total cardiac output due to their high level of vascularity. In order to understand the function of the kidney, we need to examine the plasma and composition of the blood. So I've pulled this image from Huther and McCants, page 484. Blood is composed of plasma and formed elements or blood cells. The hematocrit, or HCT, is a laboratory test that determines what percent of whole blood is composed of red blood cells. The approximate normal value for adults is 45%. When a normal hematocrit is present, the kidney receives approximately 650 milliliters of plasma per minute. Now, this is the amount of plasma that goes through the nephron. This relates to the lab value known as GFR, or glomerular filtration rate. It is considered the best measurement of renal function due to the relationship of renal blood flow. The nephron is considered the functional unit of the kidney due to its tubules, performing the tasks of formation of urine and maintenance of homeostasis. The nephron is a series of tubular subunits, including the proximal tubule, loop of Henle, and distal tubule. These subunits, along with the renal corpuscle and collecting duct, form urine and balance levels of water, hydrogen, bicarbonate, and electrolytes. Each kidney has approximately 1.2 million nephrons that work together to promote homeostatic balance. The glomerulus is the collection of capillaries that loop around and allow for blood filtration. This is similar in structure to a ball of yarn. When healthy, about 120 milliliters of blood is filtered per minute. This is the normal, healthy GFR. Most hospitals use reference ranges of greater than 60 milliliters or a whole number value less than 60 milliliters. It is rare to see a whole number value in an acute care setting greater than 60 due to stressors and deterioration in perfusion to the kidney. Proper function, however, can still occur with deterioration and some damage, as the kidneys have some resiliency, much like many other organs. Any GFR less than 90 is considered pathologic, but symptoms such as electrolyte imbalances and accumulation of wastes are not usually evident until the GFR drops below 30. Chronic kidney disease is classified by GFR. As GFR declines, so does formation of urine and the ability of the kidneys to maintain homeostasis. The basement membrane of the glomerulus is a triple layer of endothelial cells. It is lined with podocytes, which have negative ionic charges and help repel protein molecules, preventing proteinuria. We have learned that when the glomerulus is damaged by atherosclerosis, hypertension and hyperglycemia, proteinuria can occur. This indicates declining renal function as well. The juxtaglomerular apparatus is a highly specialized grouping of cells that work together to regulate renal blood flow and systemic blood pressure. The macula densa cells sense sodium levels in the blood, while the juxtaglomerular cells secrete renin in response to the detected sodium levels. This process is intricate and fascinating. When we look at this diagram, we can see that the cells are quite fragile, and their disruption or destruction can result in the loss of fluid volume, wastes, electrolytes, and acid-base balance in the body. This occurs in response to the disruption of the entire RAS process. Renal blood flow is complex and regulated by multiple forces. Autoregulation is the ability of the kidney to maintain blood flow independent of other organs and systems. This functions to maintain a fairly constant GFR over a range of arterial systolic blood pressures between 80 and 180 millimeters of mercury. Macula densa cells stimulate the afferent arteriolar vasoactivity in response to sodium concentration. Increased sodium concentration causes the macula densa to trigger afferent arteriolar vasoconstriction, decreasing the renal blood flow in the GFR. In lower sodium concentrations, the opposite occurs. This helps maintain the GFR at relatively similar rates no matter the blood pressure, fluid volume, or sodium concentration, and further prevents large fluctuations in body fluid and sodium levels with changes in blood pressure. The second method should be familiar since we've discussed SNS and PSNS regulation of renal perfusion. Sympathetic innervation in the arterioles means that stressors can alter the perfusion and the GFR through constriction or relaxation of the smooth muscles of the renal vessels. SNS stimulation through renal catecholamine release in cases of decreased blood pressure cause renal afferent arteriolar vasoconstriction and increases renal tubular sodium and water reabsorption, which increases systemic blood pressure. Lastly, RAS is coming back again in hormonal regulation of renal blood flow. Renin is formed and stored in the cells of the juxtaglomerular apparatus. Renin is released in times of decreased blood pressure, is detected in the afferent arterioles, or in decreased sodium concentrations in the distal convoluted tubule. In addition, beta-1 stimulation and prostaglandins can release renin. Urodylantin is also involved in this hormonal regulatory process. Urodylantin is a natriuretic peptide similar to BNP, which causes increased blood flow to the kidney. This results in more fluid and sodium loss and diuresis. Urodylantin is an antagonist to RAS, very similar to BNP. When considering influential hormones, we can look at extrarenal in the purple box and intrarenal in the green box. Antidiuretic hormone, or ADH, is secreted by the posterior pituitary gland in response to low blood volume. It causes reabsorption of water in the distal tubules and collecting duct. It does not affect sodium reabsorption. However, it can dilute blood, leading to hypokalemia. Increased amounts of ADH can lead to hypervolemia and may occur in the syndrome of inappropriate antidiuretic hormone, or SIADA. In too little ADH, we find dilute urine in large amounts, called diabetes insipidus. In either case, sodium levels are not affected, but fluid volume can dilute sodium, causing hyponatremia. Or fluid diuresis can lead to hypernatremia. The end hormonal product of RAS is aldosterone. This causes reabsorption of sodium in the distal tubule and loss of potassium and hydrogen. Frequent activation of RAS can lead to hypokalemia and acid-base imbalances. Atrial natriuretic peptide, ANP, is very similar to BNP. ANP is secreted from a different part of the heart and in response to atrial stretch from fluid volume overload. This results in increased urine production and a decrease in blood pressure. There is also inhibition of renin secretion, which results in increased excretion of sodium and possible hyponatremia, though this is very uncommon. In many cases, the loss of fluid volume and loss of sodium maintain a normal sodium concentration in the blood. Intrarenal hormones involve hydroxylation of vitamin D. Vitamin D is obtained through exposure of the skin to sunlight and through dietary intake. This form of vitamin D is inactive until the liver and kidney hydroxylate it to an active form. When calcium levels are low, the parathyroid releases parathyroid hormone. This stimulates the kidney to synthesize dihydroxyvitamin D, 1,2,5-OH2D3, which activates vitamin D, promoting calcium absorption in the small intestine. Without the normal action of the kidney, calcium and phosphate would be imbalanced due to an active vitamin D deficiency. Erythropoietin is released when specialized oxygen-sensitive cells in the kidney detect low blood oxygen levels. These cells then release EPO, erythropoietin, which stimulates the bone marrow to produce new red blood cells, which can overcome this renal hypoxemia. For this reason, patients with chronic kidney disease often have anemia due to poor EPO production. In the green box on this slide, we see the three main renal function laboratories. GFR is the best indicator of renal function, as we've discussed, from a laboratory perspective. Creatinine is an indicator of renal function in that it's a byproduct of muscle metabolism that is exclusively excreted by the kidney. An elevated level of creatinine indicates decreased renal function. However, it is important to note that geriatric persons can have a lower creatinine level due to decreased muscle mass, so the normal levels are stratified by age. Blood urea nitrogen, or BUN, is utilized for renal function, but it is also used to indicate hydration status. Urea is formed in the liver and then is excreted by the kidney and causes the yellow coloration of urine and gives urine its characteristic odor, especially when concentrated. BUN can be elevated due to dehydration, independent of renal function. Due to this, BUN without creatinine analysis is not used to determine renal function. Elevated BUN indicates dehydration, but in combination with elevated creatinine, this can indicate renal dysfunction. Moving on to the urinalysis, we can obtain a lot of information about renal function and overall health through a urinalysis. It's an easy test to perform, as there's a test strip that can be dipped in urine and results occur in minutes. This can be performed in a lab or at home by a patient or caregiver who is trained to do so. Urine dipsticks can help us diagnose many things such as diabetes, infection, renal calculi or stones, and give us information on fluid, electrolyte, acid-base balance, and renal function. Test strips can check for protein, glucose, white blood cells, specific gravity, and presence of blood in the urine. These tests, plus many more, can also be performed in more specific methods through a laboratory assay of urine, or the traditional hospital urinalysis, which may detect specific levels of electrolytes, hormones, toxins, waste products, cells, bacteria, and crystalline structures to indicate other conditions such as liver function. There is no better indicator of renal function than urine production. So place yourself at the bedside. You've evaluated your patient's renal labs from the morning, and they are all at normal levels. However, you've noticed that your patient has not produced urine in the past 4 hours. This should prompt you to suspect acute renal failure and obtain a new set of labs. In most cases, the more recent labs will demonstrate development of renal failure in a short amount of time. This is the duty of the nurse, using assessment and knowledge to predict or detect potential problems, intervene, and correct those problems. This demonstrates the true value of bedside nursing.